Hi, I'm Jennifer Salopek, founding editor of Wing of Zach. I'm here with Sumita Katri of the Cleveland Clinic, who was recently honored along with her team in the Clinical Care Innovations Challenge. Sumita, tell me the name of your innovation.
The name of our innovation is the physician communication project based on relationship-centered care with patients.
So, what need or gap was the initiative designed to address?
It's interesting. I think that physicians, we pretty much viewed it as an investment in our staff. I think a small group of individuals found that they were losing something in the whole caregiving process over time. You have a lot of empathy when you're in medical school, and studies have shown that it wanes over time. And in a high demand organization, high demand specialty, we all realize that we need something to keep us going. So this was definitely an investment in helping physicians have the skills and the tools to be very effective communicators.
And you're talking about communication with patients.
Communication with patients. Funny though, it does transcend beyond that.
So you're looking for a physician-patient encounter that is more rewarding for both sides.
Exactly. So it's not just patient-centered care, it's relationship-centered care, which focuses on the fact that both can benefit. And we're always used to worrying about the patient, but then we always wonder also what's in it for us, what are we getting out of it? What we're noticing when we focus on the relationship that's therapeutic and not either adversarial or going beyond boundaries, that the caregiver also benefits.
What's the difference between patient-centered care and relationship-centered care?
Well, I think that there's some subtleties there, because we all do want our patients to do well. I think though we also feel with all of this changing span of healthcare, value, see more, do with less, we feel very, often we feel burnt out, right? We feel sort of put upon, and it's natural to feel that way. So you're looking for resilience amongst all of the demands of our job. And I think that when you engage in a relationship, you get something out of it. For instance, there are days when I walk in and I'll see my full clinic list and I'm like, oh my goodness, how am I going to get through it? And when my eyes are open to it, and when I use some of the skills that I've learned through this, that have become ingrained in how I see patients, I walk out of even the first encounter saying, I love what I do.
Oh, that's terrific.
I do. It's amazing.
So how is the curriculum structured and delivered?
So I think the innovation is also not just on the content, but how it's delivered, because people have been talking about relationship-centered care for a while, but what we've decided to do is to take physicians and caregivers offline for a day into a sort of retreat type of atmosphere. So you basically get into your right brain a little bit and think about why it is you went into medicine, and then you are provided some suggestions of skills through brief didactics, and then skills-based practice sessions throughout the day. And it's a shared space that's safe, and it's peer facilitated, so physicians facilitated, not experts in communication necessarily. Because of the fact that you are around your peers, you're accepting and delivering feedback amongst your peers. So it's a safer environment, and it gets people back in touch to why they went into the profession.
That's quite a commitment of time and resources to take people offline for a full day. How many people would participate at a time?
Per class, there are anywhere from 10 to 12 participants. So for a while there was an institutional mandate to get all of the caregivers through, all of the physicians through, it was 3 sessions a day in 3 different places with 2 facilitators each. So again, another important fact is that our institution was behind it. It was an institutional buy-in to the concept, and then became really expected for all of us to gain these skills.
So at the Cleveland Clinic, how many physicians does that represent?
Nearly 4,000.
Oh my,
4,000.
Wow, that's quite an investment.
It is.
So you clearly had the support of your leadership.
Absolutely. It started as a grassroots phenomenon where people wanted to have more resilience and get some more engagement of their patients and caregivers. And then it caught on, it became word of mouth, and it spread, and then institute chairs, these are department chairs, were behind it for their staff. And then the CEO, Toby Cosgrove, and the Chief Experience Officer, Jim Merlino, they said, this is important for all of our caregivers.
Do you have any plans to roll it out to residents?
Actually, they're already rolled out to residents. Funny you ask, yeah.
Great.
And I think in the last year or so, we put 1,800 residents through the program.
Wow.
Yes.
Is there patient involvement?
Actually, currently there is not patient involvement. We have been thinking about how to transition into that. Currently we're using standardized patients, so actors who do this on a regular basis and are very, very authentic in their portrayal of patients. But we've been thinking about using real patients as well.
Sure. Sumita, how are you measuring the success of this program?
Yeah, in several ways actually. We've been checking pre and post questionnaires on burnout indices and empathy indices. We're finding that there are improvements, in other words, less burnout after they've been through the course. Caregivers have been through the course and have put this into practice. We're also seeing that there's empathy improvement among caregivers as well through other indices. Another very important thing we're looking at is that this is a common language. We also already mentioned that graduate medical education residents and fellows are going through it. What I've noticed is that we're all speaking the same language. I think I might have mentioned to you in the past that I will be in the ICU, and one of my fellows said to me, he's like, you know, I just talked to this patient's family. Have you heard of the READY model? And I said, oh, I think I have. Tell me more about this. And he said, yeah, I talked to this patient's family and I asked them what their understanding was and what they knew. And it was amazing how much insight I got.
Since the first deployment of the curriculum, have you made any significant refinements or changes?
Yeah, it's funny that you asked that. Another reason of success of this program is that we haven't been stymied by that it has to be very slow moving or so deliberate. Whenever we get feedback and we see that there's a consistency to that feedback, we look at how are we going to do it differently. One of the things that we've now incorporated more readily is something called sociodrama. Yes, so it comes from psychology and psychotherapy, where instead of physicians playing out the role of a patient in which they had a difficult communication challenge, a challenge in communication, we actually construct the scenario using the entire group. So it's not about one person and their communication challenge, but it becomes a shared experience. So very, very interesting. And we're using other exercises to get physicians comfortable to go into that space where they feel it's okay to be vulnerable while they're practicing.
Yeah, that sounds great.
It is.
So what advice do you have for others who might be interested in designing and developing a similar curriculum?
Mm-hmm. Well, we are available to talk about this at any point, but there's only so much you can talk about it. It's very important to experience it. To be truthful, I never knew about this until somebody thought that I might be interested in being a facilitator. That's what we call the teacher, so to speak.
Sure.
And only after you experience the day do you realize, wow, we all have something that we can benefit from. There's always something to learn. So the experience of the going offline for the day and sharing that peer learning and experience is something that people should come and try. And we are offering that. People can come to the
People can come and observe?
Can observe, or we are actually designing classes for people from different institutions. When there's a group interest, we're offering them throughout the year so they can come have it themselves.
Oh, terrific.
Mm-hmm.
And what are your plans for delivering the curriculum going forward now that your provider base primarily has been trained? Mm-hmm. Will you continue to offer it to new physicians as they're hired?
There's always more to do.
Mm-hmm.
So already there's ideas of advanced curricula. So they're already in place, things like delivering bad news, end-of-life discussions. We are working on a curriculum on interprofessionalism.
Mm-hmm.
All of the nurse practitioners and physician assistants are going through this. Every year there's new staff and new residents, they'll be going through this. And then finally nursing. This is a new mandate now that all nursing should go through that in a very interprofessional sort of way. So there's always something more to do.
That sounds great.
Mm-hmm.
Well, thank you so much for your time
You're
and for
welcome.
talking with me.
It's absolutely my pleasure.
Thanks.
You're welcome.